So we're going to talk about pain management, but not about opioids, okay? We're going to talk about alternatives. There's a couple of things in this chapter I'm going to talk to you about. Analgesic dose ketamine and regional block anesthesia that I personally have been doing since before the 2000s started, that most people still aren't using. I'm going to really try hard to get you to understand why you should if you're not doing it, okay? We're going to talk about a bunch of things. We're going to go through some areas fairly quickly, but I'm going to try and give you some very clear take-home points, okay? I've done literature, I've written articles about pain, done research on pain for 25 years. It is my area of focus, of interest. And it's 70% of the patients we see have pain as their primary complaint. That's been documented in the studies I've done, in multiple other studies. And of the 70% who have pain, up to 15 to 20% of them, it's chronic pain. So anyone who says chronic pain's not part of emergency medicine doesn't work in the world I work in. But if I was to tell you that 70% of your patients had bowel perforations, how good would you be in managing bowel perforations? You'd be really good. I can tell you, because I work, as I told you before, in the Center of Bariatric Excellence. And you know what? The surgeons are fantastic. They take ownership of their patients. They're always available 24 hours a day. It is a great group of guys taking care of these patients. So I don't have a bad word to say about them. I have learned things I never thought I'd ever learn. I know more about obese people than I thought I'd ever need to know. But the surgical team, they're great people. And if 70% of my patients were bariatric patients, I'd know even more. But in fact, it's only about 5% of my patients, and I'm really knowledgeable about bariatric patients. Yet 70% of our patients have pain, and yet we don't go to residency and learn about the neurobiology of pain, pain pathways, efficacy of medications based on mechanism of action, risk of addiction, avoiding addiction, the genetic background of addiction, how to deal with personality disorders. We get trained, none of that. It represents 70% of our patients, and we get no training on any of this information. It's like someone forgot what we actually do when they came up with a core curriculum. It's really remarkable. Every one of you can tell me what a carcinoid tumor has as physical presentation. Abdominal pain, flushing, and diarrhea. There are more articles published in the world about carcinoid tumor than there have been cases identified. But every one of you know what a carcinoid tumor is. 70% of patients have pain, and we're lost about what we're doing. It's really remarkable. So, how can we manage pain while reducing the use of opioids? So what are our options? The first one there is ketamine. How many of you are using analgesic dose ketamine? Only a few. How many trying to get analgesic dose ketamine to your apartment have fought the laws about, oh, they need to be treated like procedural sedation, you need monitoring, and it's just not worth the effort? Okay, you can get past that. I'm going to tell you, you need to become best buddies with everyone on your pharmacy and therapeutics committee. Okay? It is the committee you need to know inside out. I actually worked in an emergency department when I was in Montreal. I sat on the pharmacy and therapeutics committee because I was chief of the emergency department. And I went in and basically said this: we're a quaternary care center. Because we were more than a tertiary care center. We had transplant, we had the Montreal Neurologic Institute, so all of its weird cases of Smurf disease and mitochondrial disorders. And we had cardiac bypass and chemotherapy. I mean, we were truly like, we shouldn't have been in an emergency department. And I went in and I said, you know, we see everyone's patients in the emergency department, so we should have access to everyone's drugs. And I was expecting this was going to be like a 3 or 4 month battle. And the chair of the P&T committee, Pharmacy and Therapeutics Committee, said to me, "You're the first person that said that. You're right. As of today, every medication in the hospital is available in the emergency department." And I sort of went, I was ready for the fight. I had all my notes for the argument and the discussion, and he just said yes. And that was how long it took me to get every medication approved for use in the emergency department in my hospital in Montreal. How many of you had success like that? So, ketamine. Analgesic dose ketamine, I would tell you for 90% of the time, it can't be used on its own. 0.1 to 0.3 milligrams per kilo over 10 minutes. Please give it over 10 minutes. If you give it as a push, they get loopy on you and they don't like it. They see skeletons walking around the emergency department. They don't like what they feel. So take the 10 minutes to give it. Probably cuts your opioid requirements by more than 50%. In the occasional acute pain patient, it'll be all they need. So if you want to start with it first, by all means. In people who have chronic pain who come in with a flare, people with chronic regional pain syndrome, people with fibromyalgia, and they come with an acute flare of their pain, giving them that dose of ketamine followed by an infusion of the same amount per hour for 4 hours, their flare's over. They can go home and they're back to baseline. Whereas normally a flare lasts 2 to 3 weeks. So, but for fractures, for trauma patients, we found when we started doing it 20 years ago, analgesic dose ketamine infusions, they stayed in the ICU, our trauma patients, 24 hours shorter than if they didn't get the ketamine. There's lots of reasons to use it. They're wide awake talking to you. They don't need specific monitoring. You just have to get it through your P&T committee. It doesn't work in certain conditions. Patients with sickle cell disease and who have vaso-occlusive crises, ketamine doesn't work. Patients with migraines, ketamine doesn't work. Now, the nice thing about ketamine is it's been shown that if you give 0.3 milligrams per kilo to anybody, it markedly decreases the risk of depression and improves depression for about 3 months. So for all of you talking about burnout, what you really need is just every 3 months, get a shot of ketamine in the butt. You'll be a little bit loopy for 45 minutes, and then you'll be much happier for 3 months. We all have an inherent lack of ketamine in our body, apparently. All right, nitrous oxide, number 2. Nitrous oxide is a medication looking at the United States, wondering where the United States went wrong. In Australia, New Zealand, and Great Britain, 100% of emergency departments have 70% nitrous oxide. If I was to take you to Cardiff University in Wales, and you come in and you bring your little daughter or son in with a broken forearm, you get brought into the pediatric area, and every room is the same in the pediatric area. Your child's brought in, nitrous oxide, 70% is put on them. It's in the wall. The nurse then gets up the diamorphine, the heroin, and gives a dose intranasally with an atomizer. Once that starts working, they stop the nitrous oxide, they put a splint on while they're sedated, they send them off for an x-ray. All of this is done by the nurse before anybody sees the patient in terms of provider. It's all done by the nurse. The nitrous oxide, the diamorphine, the splint, the x-ray. Sort of makes us feel kind of silly, doesn't it? In Australia, 70% nitrous oxide. In Canada, every pediatric emergency department in Canada has 70% nitrous oxide. Nitrous oxide is a great drug for even a single condition. Think of the thing you never like doing. It's called disimpaction. It's the only condition where you have the same face as the patient as you're doing the procedure. Your hand's going in, the patient's going, When you give the patient nitrous oxide, at least one of you doesn't have that expression anymore. It's great. You give the patient the 70%, they titrate because it falls off when they fall asleep. No pain. You finish, you take your hand out, they're disimpacted. 1.5 minutes later, they're wide awake. No side effects from the medication. Why would you not want to have that drug in your emergency department? And the nice thing is the old 50-50 Nitrodox that people said always had a hole in the bottom of the canister because it kept being emptied. And it was being emptied because staff would be like, he. To 70%, no one abuses it. You know why? 2 breaths and you're on the floor. And there you are, lying unconscious on the floor holding a mask. It's not subtle that you've been abusing the drug. So no one abuses it. It's used around the world. It's used in Mexico. It's used in Canada. I encourage you to try and push for this. It really is a great tool in your management. You know, taking a child with a broken tibia and just putting a cast on them hurts. You give them the nitrous oxide. I had a child who came in who was needle phobic, who was 8 years old, and who had been scratched on her face by a cat and needed some suturing done. Nitrous oxide, IV started, ketamine given, nitrous oxide taken off. She didn't feel a thing. Everything was sewn up. She was sent home. Wouldn't you like that in your emergency department? Work on it. Number 3, IV Acetaminophen. Remember, it's acetaminophen. What's they say about things that come on the market? Use them before their efficacy wears off. So all the funded studies about IV acetaminophen said this was great, it's as good as morphine, it's wonderful, it's wonderful, it's wonderful. People, it's Tylenol. And all the non-funded studies, the funded studies that have been out in the last 5 years have shown what? It's Tylenol. And if you don't like what 1 gram of PO Tylenol gives as an effect, give them 2 grams of Tylenol PO. It's the same as a gram IV. There is no difference between 1 gram IV and 2 grams PO. You can't keep giving that dose because 50% gets absorbed in the liver, and if you give 3 or 4 doses, well, they're way past the 4 grams a day, and they get toxic. But for a single dose, if you want to give more Tylenol, give them 2 grams PO as a one-time dose. I don't know why you think you need to give it IV, and it's so ineffective that Canada never allowed it into the country. Because the studies show it doesn't do anything more than PO Tylenol. On we go. Acupuncture. Who is a believer with a capital B? One person? You know, all of the positive studies about acupuncture come out of China. That's not surprising. That's where it was started. Every study done in North America shows it's a sham, and it's no better than placebo. There was a great placebo study done in the BMJ. Here's the placebo study. They took people with irritable bowel, and they divided them into 3 groups. There wasn't even a placebo. There was an arm that wasn't even a placebo arm. It was you're on a waiting list. We'll get to you in 3 months. That was one group. Second group was somebody came into a room, didn't talk to them, gave them sham acupuncture. But didn't talk to them, just gave them the sham acupuncture. The third group was a boisterous person came in and said, man, we're going to solve your problem. We got the thing for you. This is going to work. You're going to see how this is going to work. And gave them sham acupuncture. So what were the results at 3 months? 20% of the people who were waiting in line, getting no treatment, got better, had no pain at 3 months. Those who got the sham acupuncture, but no interaction, 40% were better in 3 months. The people who got a boisterous, I'm behind you, rah-rah person, and got sham acupuncture, 75% were pain-free, asymptomatic at 3 months. Placebo is a wonderful thing because it actually releases your enkephalins, your endorphins, and other products. It's actually not a placebo. You are narcotizing yourself. You are giving yourself pain medication. So with that in mind, a lot of research is very hard to show any value from acupuncture. There are a couple of studies that have said that if you use 8 megahertz, a specific frequency, you can get some gateway function of blocking pain signals from C fibers. But that doesn't seem to have translated really well into clinical randomized studies. And so I think the situation is still a doubt. However, physical measures like TENS, which is sort of like acupuncture in that there's electrical vibration that causes gating effect and decreasing of pain, is effective. So TENS is just sort of like the modern version of acupuncture, and it does work. So now we're going to get, so remember ketamine I think is important. Nitrous oxide can be important. Here's where I think you need to all improve. How many of you are routinely doing ultrasound-guided nerve blocks in your emergency department? Few hands. What blocks do you do? Femoral nerve? Okay. Over here there was what? Femoral? Okay. So, I've been involved in pain for, like, I've been doing nerve blocks for, gosh, before the year 2000 started. I do ultrasound-guided nerve blocks. Heck, I do ultrasound-guided LPs. I believe it's amazing. If you go through the core curriculum, through ACEP, the International Federation for Emergency Medicine, for residency programs, none of them have as their core curriculum teaching you how to do nerve blocks. They teach you how to diagnose with ultrasound. I don't understand that. I do popliteals. I do sciatics in the butt. I do femoral nerves. I do brachial plexus blocks to reduce Colles fractures. I do blocks in the neck. I do blocks in the ribs. I block lots of things. It's been shown that if you have someone with a hip fracture and you don't treat their pain within the first few hours in a demented patient, their delirium is 9 times greater than if they get their pain treated right away. I can do something that takes away their pain in 7 minutes, has no systemic side effects like opioids do, has been shown to get them out of the hospital 24 hours faster than if they don't get it done. Effective, prevents delirium, gets them out of the hospital a day faster. How could I not be doing a femoral nerve block on every hip fracture that I see? I do median nerve blocks. I do occipital nerve blocks. It is great. The only time you can't do a nerve block in a trauma patient is if you're worried about a compartment syndrome. A tibia fracture. To do a sciatic nerve block in a tibia fracture, you risk not finding the symptoms of compartment syndrome unless you're willing to measure the compartment pressures on an ongoing basis while they have their anesthesia. Number 7 says, do not mix lidocaine with bupivacaine. Just use the latter. I use bupivacaine in about 90% of my blocks because most people are going to have pain for more than 90 minutes. The only time I use lidocaine is when they need function quickly. So if it's on their face, no one wants a drooped face for 8 hours. If it's in a finger, very few people like having a finger that can't work well and can't feel anything for 8 hours. But everywhere else, I use bupivacaine. Number 8 and 9 are poorly done studies. They showed, number 8, less pain with a block at 2 hours. That just tells me they didn't do a nerve block. Because if you do it under ultrasound, you see the anesthetic going around the nerve, right? And 7 minutes later, they're numb. What's really neat about doing ultrasound is you realize Gray's Anatomy was wrong. Gray's Anatomy doesn't represent the human body. How many times have you seen the vein, artery, nerve in that order? Right? The vein's underneath the artery, the nerve's not where it's supposed to be. Where the hell's the vein? It's all over the place. So now you realize, I remember I used to try and do femoral vein sticks and I couldn't find the vein. Ultrasound shows you why you couldn't find the vein. I've seen 10% of my patients with a vein underneath the artery. That's why you couldn't find the vein. It teaches you anatomy in a remarkable way. It gets you to do better things. Let's face it, right now in the ICU and in anesthesia, put a central line in, not using ultrasound-guided nerve care, you're in deep trouble. It's the standard of care, because if you have a complication, you didn't use ultrasound, you're dead in the water. So to put a central line in the emergency department, you should be using ultrasound. Well, if you're doing it for ultrasound for there, then literally 1.5 centimeters lateral is the brachial plexus. In you pop this fluid into the brachial plexus neurovascular sheath, complete numbness in the arm, reduce the fracture. You don't care what their ASA level is, because they're wide awake, they're talking to you the entire time. You don't have to worry about monitoring, post-sedation vomiting. They're talking to you. They're wide awake. If you didn't quite get the reduction, no problem. You do it again, because they're numb for 6 hours, they bupivacaine. It changes your practice drastically. I have someone come in with a migraine. I give them an occipital nerve block. They're pain-free in 5 minutes, and they have decreased headaches for 3 to 6 months afterwards. Why would I give them a medication that gives them side effects? I'm not going to do a nerve block in less than 5 minutes, and they're pain-free. I have someone come with torticollis. You know, and that lasts 5 to 7 days. I do ipsilateral paravertebral nerve blocks at C5, 6, 7. It takes me about 10 minutes to do that under ultrasound. They have immediate complete mobility of their neck, and the symptoms don't recur. It's resolved. It's over. How many of you have a treatment like that for torticollis? The list of reasons why you can do ultrasound-guided nerve blocks and how it affects your practice is literally this long. So you need to think about this. You need to take the courses, because like anything else, you have to train to do it. I was very fortunate. Many, many years ago, I went to a World Congress in pain, and it was in Glasgow. Glasgow is a place where the sun never comes out, it seems. Apparently, I asked people, I was in Glasgow, so I said, so what do you do for summer? And they said, well, we don't have summer. I said, so what do you do around here for summer? He says, oh, we go somewhere else. That's what the people in Glasgow told me. We sometimes get a couple of nice weeks in May, but the rest of the summer's a wash. And they said, we can fly to Spain and the beaches in Spain for 90 euros return. I'm thinking, I wouldn't stay in Glasgow either at that price. But they had this 2-day course where these guys gave these great talks in the morning. In the afternoon, they had fresh frozen cadavers and PhD students. They didn't have medical students. They had PhD students who were live people, so you could put ultrasound on them, learn the anatomy. You'd immediately go over to a cadaver right beside them and practice your nerve blocks on the cadavers. It was fantastic. I learned more in those 2 days than I have in any other course. When I set up for our pain clinics practice for ultrasound-guided nerve blocks, we set up cadaver dissections to show them where the needle went, how it looked like under ultrasound, where the nerves were, where the blood vessels were, so they could see it. And then we had partially dissected cadavers to show them the anatomy that they were seeing on this other portion over here. So I always have recommended cadaver-based nerve block courses. There are lots of them around, but you need to get the training. But it has completely changed my practice in so many ways. I do nerve blocks at least 3 or 4 times a shift. At least 3 or 4 times a shift. Less opioids, much better pain relief, long effective pain relief. It's sort of like tastes great, less filling. So I encourage you to take the courses necessary. And by the way, it has nothing to do with quality of care. They pay really, really well. I'm in Canada where we don't charge anywhere near as much as you guys do. For me to do a femoral nerve block and reduce a pediatric femur fracture is $600 in my pocket. And it's great for the kid. Imagine a femur fracture, wide awake, 0 pain, reduce it with no pain. When was the last time you guys did that? Oh, that's right, you've never done it. That's what nerve blocks do. Okay? So think about it very much. Ketamine, nitrous oxide, a regional anesthesia. Physical measures, they talk about TENS there. Topical medications. Oh, number 15. Number 15 reiterates there's no such thing as muscle relaxants by mouth. Remember, all your muscles contract using acetylcholine. There's a really effective muscle relaxant on the market. It's called Curare. It blocks the release of acetylcholine. As far as I know, there is no pill on the market that says, oh, your acetylcholine when your muscle's in spasm is different than the acetylcholine in every other muscle of your body. Will only go work as a smart bomb on the one in the spastic muscle. It doesn't work that way. So what most muscle relaxants do is give you a dry mouth and make you drowsy, but it doesn't relax the muscle. The only oral medication approved for large muscle spasm and dystonia is benztropine, Cogentin. And in some case series, it's been very effective in decreasing pain and large muscle back spasm. I've actually had patients come back to emergency drug seeking. I ask them why they're back. Well, we don't want any of that Percocet shit. Can we have some more benztropine for a couple more days? Because I'm able to get around and do my work when I'm taking it. But none of the other stuff has been shown to be effective in placebo-controlled studies. Topical medications, we know that topical NSAIDs are not topical. They're absorbed to go through your blood and work like any other NSAID. They have the same renal and GI side effects and CHF side effects as oral NSAIDs. But compound pharmacists can make topical agents with ketamine and lidocaine and other things in them to relieve pain locally, because people can't tolerate, they don't work, PO lidocaine and PO ketamine don't work very well, but topical creams that compound pharmacists make do work. To finish up, non-opioid analgesics. Just remember, tramadol is an opiate. It must be a really bad opiate because it sells for the same price on the street as it does at the pharmacist. That tells you everything you need to know. OxyContin sells for $1 to $2 per milligram on the street. So an Oxy 80 is anywhere from 80 to 160 bucks. Tramadol is $5 a pill at the pharmacist, and it's $5 a pill on the street, which tell you it doesn't do much of anything. But it is an opiate, and 14% of people last surveyed who abuse heroin say they started by taking tramadol. So it does lead to addiction. And a lot of us were told by the pharmaceutical industry it was a safe drug, you can prescribe it, blah, 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 blah. Funny, 15 years earlier, we're told the same thing about OxyContin. Will we ever learn? All right. That's it. Questions? So Botox for chronic headache and neck pain is very effective, provided you understand what you're doing. So people with chronic mixed neck and head pain, come on up, Raman. With chronic neck and head pain, the reason you give Botox is not to take away their pain. Right. I know that sounds silly, but I'll get there. What you do is you actually paralyze the muscles in the back of their head, which forces them to have better posture, and they have to literally stand straight with their head back, or else their head flops forward because the muscles in the back are too weak. And by forcing them to maintain their head with perfect posture, you take all the stress off the muscles, and that's how it gets rid of their pain. It's forced proper posture. The studies aren't good. There's actually 2 studies out of Spain that showed that Benadryl IV is very effective. If you give an NSAID and Benadryl, because there are H1 receptors, on your smooth muscle. And there's 2 very well done studies out of Spain that have shown that Benadryl may be effective for renal colic. But right now, lidocaine has not been shown in my mind. It's all case series. There hasn't been a proper study to justify using it.